and he has a master's in public health, as well as he trained as a fellow in pediatric nephrology and is a pediatric nephrologist in US in the Washington University. And he is well known for a number of things. I think all of us know that he has a great interest in transplant, especially infections following transplant, and BK virus and PTLD. He's an authority, and many of us, and not only us from India, but people from all over the world reach out to him when they have patients who have been transplanted and who are running into problems. And so I would like to say that he's done a lot of research work and has a lot of research support, and has mentored many students in pediatric nephrology as well as pediatrics, and is a great teacher. So it's a pleasure to have you. He's currently, I forgot to mention that, he's Professor and Division Chief Vice Chair for Clinical Investigation. And we welcome you to this gathering and request you to deliver your talk.
Thank you, madam. I'm trying to share my screen. If you could just give me privileges to do that. I will shift to the slide view presentation. Can all of you see my slides?
It quite clearly.
Very good. So thank you, madam, again for the very kind introduction, and such an honor to be here. I'm visiting Mumbai. I have my entire family lives here, and I had not been to SRCC hospital before, so I'm again thrilled to be able to see what has happened, because now you have a pediatric multi-specialty hospital besides Wadia to be able to do so many other things, and how the pediatric nephrology community has expanded here too. This topic that I am speaking to you about is a relatively recent interest of mine, the long-term renovascular complication prematurity. And what I'm going to discuss with you are, the first half will relate to what are the data in terms of the need of the problems that occur and what percentage of children get them. And then the later part will go over what are the mechanisms and what some of the mechanisms that we are planning to study. And then what could they lead to in treatments potentially down the road. So in the US, we always have to put a disclosure slide up. I don't have any disclosures that are relevant to this, but I do have several that are related to my transplantation. I have certain research grants from the National Institutes of Health. They're called R01 grants from two different branches of the NIH. The DDK branch is diabetes, digestive and kidney disease, and AID is allergy and infection. I also have some research grants from some companies, as you can see here. I do have actually something with both these two companies too. We have a collaborative called Napritics, which many of you may have heard of. I'm on the board of directors. I currently chair the section on nephrology for our American Academy of Pediatrics, and I'm on the council for the ASPN. As you heard from Madam, PTLD has been my area of passion for many years. I won't talk about that today, but just mentioning to you that we had published our first edition of the book back in 2009. And then the second edition actually just got released a few weeks ago and is available through Springer's website. The electronic version will be available also, I think mid-April right now, it's the hardcover. And then many of you probably are familiar with, through IPNA, the International Pediatric Nephrology Association. And they're doing a virtual pediatric kidney transplant update later this month. This is being arranged by Siddharth Sethi. And so I'll be one of the speakers for that later this month. And that is free registration for all of you who might be interested. So my objectives for today are, one, to avoid mention of a certain virus pandemic. So you will not hear the C word from me at all during this talk. I think we've all heard enough of that word for the last 10, 12 months. What I will try to talk about are to understand what are the system derangements that occurs in survivors of prematurity. Many of them are subtle, and I will be focusing primarily on the renovascular problems. The kidney, the heart, and the blood vessels are all interconnected in many ways. This should be a topic I hope of broad interest to many of you, and it is multidisciplinary in nature. So the way we are actually going to study it, as you will see, involves a multidisciplinary group. And what we hope to be able to do is look at some of the newer putative mechanisms, and I will discuss with you some of the existing ones that are known. What you can see in this photograph is the institution where I work, St. Louis Children's Hospital, and then Barnes Jewish Hospital.
Because just a moment, your slides are not moving. Can you put it on slideshow?
It's on slideshow here for me.
It's not coming on slideshow as for us.
Okay, 1 second. I'm going to stop.
We are seeing only your first slide.
Okay. Let's try. You were able to see our slide? Not yet?
Yeah, we can see it.
Oh, you could not yet.
Yeah.
So now you can see this slide.
Yeah.
Okay, so the previous slide, I'll just go back to. So this was the book I was talking about, and this is the kidney transplant update. And then here is the objectives. And so this is a large medical campus that you can see. Washington University Medical School is also within the same campus of buildings. The famous Arch of St. Louis is actually right over here. It's on the eastern edge of the city, right next to the river. And then this is the western edge of the city that I'm showing you where we are. So before talking about what are the issues related to survivors of prematurity, I want to first go over some of the definitions that are important in understanding the different types of. Prematurity is conventionally defined as less than 37 weeks gestation. Low birth weight is conventionally defined as less than 2,500 grams or 2.5 kilos. But then there are other categories even beyond that. So very low birth weight has been defined as less than 1,500 grams. And that generally, but not completely, overlaps with another category called either extreme prematurity or extremely low gestational age newborn. So EP or LGAN are the terms you'll see used in the literature. And that has been used for children born at less than 28 weeks gestation. And there is an even further category called extreme low birth weight, which is less than 1,000 grams. So this graph that you can see here, the bar graphs, show the rates of prematurity by year that have occurred in the United States. And surprisingly, both global and the United States preterm birth proportion is either steady or in fact increasing a little bit, but there hasn't been a drop that you would expect with so many other advances in prenatal care and obstetrics and general care. That rate of prematurity has held steady around 10, 11% for quite a long time. And then what has improved is that these babies are surviving. And so more and more of these survive to childhood and then to adulthood. So the cumulative number of children who have gotten to adulthood but were premature or low birth weight is a constantly increasing number. As with many other things in the United States, disparities, particularly racial disparities, are seen here too. In the case of white population or the Asian populations, it's relatively lower rates of prematurity and then highest in the Black infants. Now that improving extended survival, in the past we used to say that if you were 1,500 grams, you were likely to survive. Taking that further and further down to lower and lower gestational age or birth weight categories that can get to survive. So each more recent decade has seen more survival of such babies. And with that prevalence going up, there is this increasing public health relevance because now we also have more data that show associations of preterm birth with multiple system abnormalities in school age, in childhood, and even in adulthood. So this slide shows you the survival by different gestational ages, each by a different color here. This is the adjusted hazard ratio for mortality on the y-axis, and then the attained age on the x-axis. And using the reference frame as the black line, which is the full term of 39 to 42 week gestational age, you can see that even for slight borderline prematurity, there is a higher mortality risk early on, but then it comes down to meet the black line, and then it goes up again. So that beyond the age of 30, there's actually a slightly higher mortality even in these borderline premature babies. And as you get further down, whether it's the blue, green, or red lines, up to 22, 27 weeks, you can see that that U shape becomes a little more steep. So high mortality early. As you get into that 10 to 20-year age group decade, and then after the age of 20, that increase so that there's an increasing mortality afterwards.
Because just excuse me, I think the audio is a little inconstant. At times we're hearing you clearly, at times not so clearly. So maybe if you could go closer to the audio or something, maybe clearer.
How is this now?
Yeah, this is better. Yeah.
I brought the computer right at the edge of the table now.
Okay.
Hopefully
Yeah.
this will be consistent. So these U-shaped curves, it's hard to explain by just socioeconomic differences or demographics. And even if you account for congenital anomalies, they still retain. So we don't understand why the second wave of mortality occurs once these children who are born preterm or low birth weight get into adulthood. And we know that the intrauterine growth restriction or the prematurity are both associated with multiple system disorders, particularly from what we believe is some form of metabolic programming and epigenetic modifications, what you'll hear later about the Barker hypothesis, and then maybe some abnormal nutrition too. So this can affect all these different systems that I've listed along these different blue bars. Issues that are directly relevant to us, hypertension and obesity, renal and hepatic disease. I've already shown you some data from investigator at he's actually in community and family medicine, but he's worked with researchers in the Scandinavian countries. Scandinavian countries have incredible data right from the period of birth all the way to the period of death, cradle to grave as it's called, on health disorders, which is unique to that part of the world. And so they're able to show how you have increased risks for different types of diseases based on premature, late preterm, very preterm, etc. Similar type curves you saw for mortality occur here for what is this disorder, sleep disorder, breathing, or obstructive sleep apnea type syndromes. And you can see that in this particular curve, this is for type 2 diabetes. So if the reference line for the full-term children is here, again, the more premature you are, male or female, you can see that the risks go up. And for the red line, which is less than 34 weeks, solid for female or dashed for male, it's 1.5 to 2.5 times higher. And the same is true for cardiovascular disease. Here you can see for ischemic heart disease. So the reference line and then the post-term ones stay roughly there, but then the preterm and the early term ones go up once you get beyond the age of about 25. And when you're looking at hypertension, again, what you see with the reference line being here is that there is the group that's very extremely preterm, and that has this line of fairly steady increased risk. And the different things are a consistent theme across different diseases that the increased risk occurs. Not that it means a huge amount, it's not tenfold, but still these things add up over the period of time. And so when they're able to look at heart failure risk in Sweden with gestational ages, you can see how it goes up on an incidence rate ratio basis. And then for blood pressure, people have looked at different studies. They compared systolic and diastolic blood pressures in the very low birth weight group or the extremely low birth weight group. They've divided the VLBWs to extremely low or the 1,001 to 1,500 grams. And you can see systolic blood pressure risk fold is in the 3.5 to 3.8 range. And if you look at women especially, it goes up even higher, 4.5 to 5-fold range. Diastolics do not go up as much as systolic, but these do lead to a fairly significant instance of hypertension in these young adults. And then if you do echocardiograms for these young adults, and this is work done by a group at Oxford University in England, here what you can see is left ventricular mass in the left side. And the at terms are the two red bars, and then the green and the blue bars represent those who are born at term or at young adult, or the preterms who are young adults, which is these blue bars. You can see the increase. And the same is actually true if you look at right ventricular mass, which is this graph over here. And here you can actually see a dose response curve. The more premature you are, the greater the right ventricular mass that is going to be present in the young adults that were born preterm. Now, what about kidney disease? So again, several studies exist, and what I've done is compiled many of those studies into the tables you'll see on this in the next 2-3 slides. And these studies are again fairly consistent in what they show. Each group has used a different population, and they've used different criteria. For instance, the first study is looking at is a population study of Sweden, looking at 2 different age groups, but looking at low birth weight and calculating an adjusted hazard ratio for chronic kidney disease. And you can see it's very high in the younger age group, goes down when you get to the older age group because the general population incidence of chronic kidney disease goes up. So it's a relative number. And then the next group was looking in Norway. And again, countries in that area are able to go through a whole lifespan. So they're looking at age 50 over here. And the adjusted hazard ratio for end-stage kidney disease, not just chronic kidney disease, but that final stage was 1.6-fold higher. And in those who were small for gestational age, that ratio was about 1.44. White did a meta-analysis and looked at low birth weight and gave these adjusted hazard ratios for not just chronic kidney disease, but albuminuria or end-stage kidney disease. A very recent poster that was presented in last year's American Society of Nephrology meeting, I don't think it's been published yet as a full paper. This was from New York and Montefiore, and they looked at the adolescent population low birth weight using a large national database that is a nutritional survey. And they looked at 2 different equations, the older Cunahan-Barrett, the newer bedside Seekert-Schwartz equation. And similar numbers, adjusted hazard ratio of 1.5, and 21% of this population and 30% here by these equations had actually a GFR of less than 90. So now if you come to the very low birth weight population, which is less than 1,500 grams, and you look at this 1 to 3 age group, 12 to 15, or in the 14-year age group, depending on the size of the population, what they did, you see that patients had elevated systolic blood pressure 8 millimeters higher, reduced GFR in about 30%, 10% to 11% prevalence of frank hypertension, and particularly rising to 20% if that very low birth weight survivor would go on to become overweight or obese. And luckily the creatinines were not abnormal, but they were a little bit higher, 8-point lower GFR and higher albumin creatinine ratio also by a small amount. So why are these important? Blood pressure rises with age. And so if you start on the higher end up front, you're likely to get much higher as you age into mid-adulthood or late adulthood. And GFR rises early on in life, and then it hits its peak at about 30, 40. And then after the age of 50, the GFR actually goes down in the elderly. So instead of starting in the midpoint or the upper end, if you're starting down here, then you're actually going to be in much more severe chronic kidney disease at relatively younger ages. That's why this can be very important. So here are studies of chronic kidney disease by birth weight. Now we're looking at the extremely low birth weight, less than 1,000 grams. 2 different studies that looked at them at around 6 years of age or at age 25 from Poland and Australia. And you can actually see creatinine increases in some of them when you use more sensitive tests, such as cystatin C. It's only a 0.05 milligram per liter difference, but it can add up over time and would probably lead to a higher incidence of chronic kidney disease when people are in the older age group. And then renal volume is lower in this group. Some have albuminuria and blood pressure can be a little bit higher. So fairly consistent themes across the board. And if you look at it by gestational age, again, the same thing, extreme prematurity here, same thing, LGANS, which is the same term, looking at was around 2 years of age. Here looking at age 7 or 6. The first three studies all showed, whether it was Sweden or the United States, that there were changes in terms of blood pressure particularly, and some changes in terms of renal volume or higher cystatin C and therefore slightly lower GFRs. The only study that contradicted that was this study from UK and Ireland, where they did not find a difference in the blood pressure. This study actually just came out recently by Ashkenazian group. Sangeeta Mugarani was the senior author on the study. She's a pediatric nephrologist in Seattle. In Seattle, they had been conducting this multi-center study called the Peanut, which was actually a randomized controlled trial of giving erythropoietin to extremely low gestation age newborns, primarily for other reasons. Erythropoietin's receptors are expressed on multiple tissues in the growing fetus. And then Sangeeta and the nephrology colleagues listed over here had the opportunity to look at a variety of outcomes both in the first few months of life and at 24 months of age. This table that I'm showing you here are the 24 months data. They didn't have the data on everybody, but they still had a sizable proportion, about 400 each group, and then some proportion of that they were able to do 24-month specific analysis of the eGFR. You can see that 16% of those had an eGFR less than 90, and about 35% of them had albuminuria greater than the definition, and systolic blood pressure was elevated in about 20 to 25%, and diastolic blood pressure was elevated in about 30 to 40%. Both these groups were actually similar. The use of erythropoietin did not make a difference in whether these outcomes occurred. So that didn't change their outlook, but the prevalence of these kind of conditions at 2 years of age is what I wanted to highlight. And then this is just briefly that with this, you can also see other problems in the liver. Steatohepatitis is another problem. It's just multi-system disease. So summarizing here, survivors who are largely healthy, even when they look healthy, prematurity can associate with multiple adverse outcomes. And if you look for them, you find them more. And so these are things we have to be cognizant about and be aware of when to look. And then this shows you again our campus buildings overlooking this very large park that you'll see another photograph of later. My office is on the 10th floor of this building, so I have a window view of the park every day.
Vikas, they just called up to say the audio is fluctuating.
Okay. Still fluctuating. I'll try to increase the audio on slides. No, I think I stopped.
Yeah, we can see the slides.
Okay.
No, basically, I get the UI UX wallet now. They will belong to that capability. So they are not ready for that. So if you look at the mobile device.
I turned off my own video. The different things we go through to try to do this. So where is my Zoom control? Turn off my own video. So now I'll just briefly cover some of the mechanisms involved in these renal and cardiovascular diseases. So on the left, what you acute ischemic or toxin injury in the newborn period. Many of these babies go through a lot of insults. They can develop stiffer arteries over the course of development and beyond. And then there's also the issues of reduced endowment. Nephrogenesis completes by 36 weeks, cardiac myocytes by about 40 weeks. And so if you have reduced endowment of those, they could lead to hypertrophy of the remaining normal myocytes and nephrons, and then further fibrosis. So the term developmental origins of health and disease is very familiar, I think, to all of you. This is what Barker had started as the Barker hypothesis, where there's maternal placental stress and then epigenomic changes in the fetus, which can lead to the growth restriction, the need to have more stored energy, but which can cause obesity, metabolic pathways that change to diabetes, and then cell numbers, which directly affects the heart and the kidney and these problems as you see here. And we think that all of these are active, but at a molecular cellular level, what can we do about them and how can we change them is not easy, because these things, what's happened has happened. Some of these changes, just to show you very briefly how they might work, if you have a population that has two different genotypes, T and A, and they mix like this over here, and in situations where there is famine versus excessive food, you will change the proportion of them. So the T ones, or the non-thrifty, might become more dominant in one group. And then when there's adequate food, that T polymorphism loses its selective advantage, but now these people are more obese over here. And then on this side, if you start with adequate early nutrition or malnutrition in the in utero womb, and then if you have genetics in the post side, happen there, and you could have either a selective disadvantage or an advantage. Some of those might be severe enough that the embryo actually dies. Some will be without any influence, so then you have otherwise healthy adults. But some on this right side over here leads to a competitive advantage in some situations, and then eventually that becomes mal development and leads to metabolic syndromes. So what else beyond that? Because there are several negative studies too. The Barker hypothesis is not universally accepted because it has not been proven across every study. And what I want to introduce you to is something about the gut bacterial microbiome. So the microbiome, as many of you are probably familiar with, is the group of organisms, microorganisms that live in our body, typically bacteria and viruses, typically in the intestine and in the
I want to show you something.
Please, all participants, please mute your audio.
So the microbiome has become a very hot topic in terms of what it can actually do to the body. People used to think that all these organisms were living on their own and not interacting with our body, but that has been proven to be quite different. And in fact, at our university, Washington University, Jeffrey Gordon, who is considered the father of microbiome studies, has led entire groups that have looked at how the gut intestinal microbiome affects the entire body in so many different ways. And a lot of what I'm going to talk to you about now relates to that. So when a baby is born, the intestinal area cavity is actually sterile without any organisms. But over the first 1,000 days of life, there's a tremendous exposure to different bacteria, tremendous adaptation and development of a different microbial profile within that intestinal cavity. And so what you see over here in this slide is that the most normal babies will have a specific pattern of colonization, and they'll start with very few groups such as enterobacteria in the beginning. E. coli would be a typical enterobacterium, or proteobacteria is the category which this comes under. And then lactobacillus and bifidobacteria come up later. And through the months, as you get to 1 to 3 years, what you see is an evolution towards what would be a more adult microbiome, which will have more of anaerobic bacteria, particularly the Bacteroides or the Firmicutes, and then very small proportions of the proteobacteria. So E. coli should not be very common in our intestinal tract at the ages beyond 3. But when there is dysbiosis, which is a term that means that the proportion of the different bacteria is abnormal, it actually can lead to a variety of different things, such as antibiotics causing that, or prematurity. So you can have a variety of influences related to viruses, bacteria, and what they can do to the different structures. And they create specific epigenetic signatures from that. It can change the barrier properties of the gut intestinal mucosa and their protective role, can lead to late onset inflammatory diseases, cardiovascular, obesity, diabetes. And many of these have actually been associated with specific disease states and particular patterns, the greater proteobacteria, and then reductions of what are called butyrate producing bacteria, such as the Roseburia species. And this theme is something you will see me talk about next few slides as occurring even in the kidney world. So here in chronic kidney disease, when people have worked, they found that most healthy gut microbiomes will efficiently ferment carbohydrates to what are called short-chain fatty acids or SCFAs. But in chronic kidney disease, from multiple different studies, what happens is that in a variety of situations, for just not an issue of the fibers in the diet, but also for a variety of protein reduction or uremia, you'll have reduced short chain fatty acid production, less saccharolytic microbacteria, more protein in the gut, and the barrier changes, more proteolytic microbacteria come up. This changes the immune response, and inflammatory response increases the nitrogenous waste and uremic toxins. So if you put that all together, chronic kidney disease and end-stage kidney disease actually have a relationship to the dysbiosis of the microbiome. And there are very specific bacterial byproducts of these constituents that have been found to be elevated. The ones that are listed here, these four are the ones studied the most, particularly the first three, p-cresol, indoxyl sulfate, and trimethylenamine oxide. And each of them has very specific roles in development of inflammation, endothelial dysfunction, cholesterol transport dysfunction, and endoplasmic reticulum stress, which therefore can lead to atherosclerosis, vascular calcification, cardiovascular disease, and all-cause mortality. And this is again starting from chronic kidney disease. But even in chronic kidney disease per se, people have shown that progression of chronic kidney disease can be worse when you have the same dysbiotic pattern of higher amounts of proteobacteria, lower amounts of the Roseburia species. And from that, these abnormal bacterial patterns, again, the same metabolites are seen in higher proportions, and then they affect endothelium not just in general, but also within the kidney itself. And if you have higher amounts of short chain fatty acids, then that actually mitigates some of the problems seen. And then this is an example of a review paper that came out 2-3 years ago, which actually looked at all these changes just from chronic kidney disease and what they do to kidney function progression. So what do we need at this point is really a prospective study of the gut microbiome. Most of the studies I've shown, in fact all of them, were cross-sectional studies. They looked at one time point and then they tried to look at another time point and make an extrapolation, but did not have sequential testing. And how do you do it when these are mostly adults? What do you do when you have children? And particularly in prematurity, these things could start very early. And if you want to do microbiome studies, you have to have multiple stool collections. It's really unfeasible in real life to conduct such a long study today. But what if we had cohorts that we had microbiome data on and well annotated clinical data at birth, and those were still available today and could be studied? So that's what we actually have available at my institution. In 2009 to 2013, a group of investigators, this was before my time, actually had looked at a cohort of babies that they were studying for necrotizing enterocolitis. That is what NEC stands for. And they enrolled these very large cohort of babies, almost 500, very low birth weight, and performed serial microbiome studies on them, and also collected a lot of very intense clinical data, which they still had. And then they built into their consent form to recontact them at later life. So we actually did that recently. We were able to contact a fair number of them. A small number had passed away during that newborn period, and some of them lived very far away. We do not feel it was worth contacting them. And then we asked some of the ones we did contact if they would be interested in future studies, and got a fair number to do that. And then simultaneously, the same group also was looking at a twin cohort, which was 40 near-term twin pairs, generally healthy, born in the same years, and also with sequential microbiome studies and early life metadata. And same recontact permission built into the informed consent. And in fact, here I've written greater than 60, but in fact, almost all 80 have agreed to be participating in future studies. And this group, which was led by Barb Warner, our neonatology chief now, and Phil Tarr, who is our GI chief, published a lot of papers in major journals, Lancet here, Nature here, related to these cohorts. And what they found in the Lancet paper was that those babies who went on to develop necrotizing enterocolitis, the cases was the controls. You can see here the gamma proteobacteria proportions jumped up so much in the ones that as stool collections that preceded the neck versus the ones who were controls generally had a stable and lower proportion. Here it was this increasing number. And conversely, the negative acutes and Clostridia proportions, anaerobes, went down as the proteobacteria went down. So this pattern is similar to the pattern that I told you about earlier, where you have more proteobacteria and less of the anaerobes. And if you're seeing it in the newborn period, then are those babies at risk for chronic kidney and cardiovascular disease today? And that group actually went on to do some other studies. Our colleagues actually did. These were Philip Levy was a neonatologist, as was Hamvas, but Gautam Singh was a cardiologist at our center then. He's now chief of cardiology in Detroit. And they published that they found in some of those babies at 1 year of age that there was pulmonary vascular disease. And they created a new parameter, pulmonary artery acceleration time. And the lower value is actually a measure of pulmonary hypertension. And then they did other studies looking at left ventricular deformation mechanics by something called spectral tracking, which is another novelty or innovation they created. Now, remember, as I told you, in this is what happens to the GFR. But what happens to the GFR in this early period? So in the preterms, in a full-term baby, the GFR would start at about 30 and jump to 120 very quickly, and then stay in that range between 120 to 140 throughout. Preterm babies, it's much lower. It's a much slower progression upwards. It may not even hit that same peak till later. So the curve for preterm babies is very different. But serum creatinine, which I've overlaid over here, starts at the maternal level on day 1, drops in 2 weeks to about 0.3, 0.4, and then rises slowly to about 1.0, 0.9 maybe, and late adolescence, and then stays like that even as you're losing GFR in the elderly. Cystatin C actually doesn't do that. Cystatin C really does reflect in this age here, the 0 to 2 age and the post 50 age, the real changes in GFR that are occurring with creatinine. So I've worked with serum cystatin C now for quite a while, and this was another reason for me to get interested in this particular project. Cystatin C in the gestational age groups we're talking about, there are different equations that have been created. Here is one by Carolyn Abatol, who has worked in this area in Miami for a long time. And you can see how she shows that the groups that have cystatin C versus creatinine, or just a creatinine equation of cystatin C, you see differences. The creatinine equations look much worse compared to what the cystatin C equation or the combined equation looks like. And we had the opportunity from that cohort, we had frozen serum samples from which we were able to take some shavings and actually measure the cystatin C level. Anjana Ranganath, student who worked with me at the time, and we looked at that cohort of the necrotizing enterocolitis babies. In about 180 of those samples, we found this wide variation in the levels according to what their gestational age was and the day of life, which is up here. And then about 49 of the 180, about a quarter of them, had a cystatin C level that exceeded 2 milligrams per liter, which from the previous slide was the level at which you would be considered abnormal at any gestation. So think of this, a quarter of that cohort had a cystatin C level from a serum sample near their discharge that is already abnormal. So coming back to the topic of gut dysbiosis, we've already talked about how low birth weight children can have proteobacteria, less anaerobes. And we know that those same patterns are similarly seen in established chronic kidney disease, established cardiovascular disease, and may be mediated through these metabolites. So when did it actually start? Could the neonatal dysbiosis that's occurring at very low birth weight predispose to this chronic kidney metabolic profile? That actually is the basis of the group that we are hoping to study. We have not yet started the study. We're awaiting the funding from the NIH, but we have called it Super Kids. This is the acronym we created for survivors of prematurity or low birth weight for cardiovascular, kidney, and metabolic problems. And this is a collaboration between my neonatal division chief, my GI division chief, and myself. And our hypotheses are that this neonatal gut dysbiosis via the inflammatory mediators will predispose to these later systemic abnormalities in those born very low birth weight or very premature. Short term, we'll study those profiles and both the microbiome from back then and the current age microbiome. All these children now are in the 8 to 12-year age group. And we will also study the metabolic profile currently with those metabolites I mentioned. Long term, we hope that this will inform the newborn and childhood care for this growing population. And since you can change the gut microbiome, you could potentially have interventions that might prevent some of these young adult morbidities. Again, this was the aims we wrote in our grant, where we would look at it in the low birth weight or near-term twin and compare those. So the near-term twin is our comparator group. It's not an ideal healthy control, but it is a group that has the same type of microbiome and clinical data from the newborn period, and therefore very valuable to us. And we'll measure in plasma these various metabolites. We'll do further microbiome studies. We'll do chronic kidney disease tests, as you can see here, including renal volume by ultrasound, albuminuria, and cystatin C. And then we'll look at systemic hypertension, arterial stiffness, and then echocardiographic measures. For the arterial stiffness, we're going to use a device that you see over here, which measures what's called pulse wave velocity. So most vessels that are compliant will reflect back the wave that comes from the cardiac contraction through the aorta. They'll reflect it after the heart has finished its refractory period. But a stiffer blood vessel actually reflects it back too fast and sends the wave back to the heart when it's not quite ready. And multiple studies in adults and now in children have shown that you can actually look at these pulse wave analysis and pulse wave velocity. And those correlate better with long-term cardiac outcomes than just blood pressure, peripheral blood pressure measurements alone. And we have actually had the chance to look at how pulse wave velocity behaves in children who had either obesity alone or hypertension alone or both. This was work by a former fellow of mine, Nazia. And what we found was that each one of them, obesity and hypertension, increased the pulse wave velocity compared to controlled children who are healthy and lean. The combination of the two was not multiplicative, so that was one good thing, but both of these conditions independently did make the arterioles both more stiff. So to summarize over here, very low birth weight babies can increasingly survive, and even in those without major congenital or neurological impairments, subtle impairments are now well known, and they can lead to overt morbidities in adulthood, which are the ones listed here. And the neonatal gut microbial dysbiosis, or maybe the ones in their current childhood age, could associate with these changes, and they may be mediated through these metabolite profiles I've shown you. So now there are opportunities for intervention. We can control blood pressure in all ages, and those of you who follow the adult literature, SGLT2 inhibitors have a really hot class of drugs for reducing the progression of chronic kidney disease in adults on top of what these inhibitors might do. So those interventions exist, but I think that the microbiome manipulations that could occur based on what we find would be another set of opportunities. What does this mean for all of you? As pediatricians, when you're seeing a former premature baby, especially one that was a very low birth weight, monitor the blood pressure at each visit, monitor the analysis for proteinuria at each visit, watch for rebound weight gain towards obesity. That can be particularly detrimental in this group, and then consider an early referral to specialists in the various categories for which the disorders we've talked about. Likely, these children will have future worse problems when they get into adulthood. So I'll just end up here by acknowledging all the various people who worked in this. Many of these people I've mentioned already. Chuck Goss and Hongji Gu and Ken Sheckman are our biostatistics group. And then these are the various research coordinators who worked through these studies: Laura, Leslie, Krista, Malik, and Michael for the cystatin C. Here is that other view of Forest Park. These are our buildings, and you can see it's a very large park, 1,600 acres or so. This photograph was taken when there was the great hot air balloon race over here. So these balloons all go up into the sky, and we had a spectacular view from our buildings. I'll end up here with showing you some of our physicians and my nurses. This photograph on the left shows our 10 senior faculty physicians, plus our 2 nurse practitioners and the 2 clinic nurses on the Washington University side. And then our doctors, all of us are affiliated with the Children's Hospital, which has a very large team of dialysis nurses. Our 6-bed dialysis unit actually has 9 nurses with it. And then not shown in these photographs is our extensive research team and our extensive transplant team. And you can see here is our website, our Facebook page, and our Twitter page. So just feel free to reach out to us through any of these, but I'm happy to take any questions that you might have. Hopefully this talk was of value to you.
Thank you, Vikas, for this excellent talk and the insights into what could happen to these babies born preterm, which the neonatologists take so much trouble over. And I think it's a great eye-opener that so many things could happen and a number of pathophysiological mechanisms that are interacting to produce that. So maybe one day we'll know how to treat them better to prevent these future problems. I open the talk to questions. So all those who are attending, whoever wants to ask a question, please unmute yourself and ask what you would like to.
Can I ask a question, Dr. Vikas? This
Yes,
is
please.
so I think what all of us are really wondering is, do you see that, as you have rightly said, that many of these issues have already happened by the time the child comes to us? So it's not like we can do anything correctable at the moment. We can monitor and look for these complications. Do you see with this gut microbiome, etc., coming into play, do you see that we would really have a role to prevent progression of these conditions in the future?
For those babies that will be born now onwards, if our studies reveal things that we can intervene in, it may be possible to do microbiome studies early in the newborn period. The cost of doing those kind of studies has also dropped quite a bit, and the technology has gotten better. Previously, it was 16S ribosomal RNA sequencing. Now there is the ability to do whole genome sequencing of all these bacteria at one go through metagenomic techniques. And I think that that is something I'm hopeful will be the case. For the babies who are already now into childhood or young adulthood, for them really what we can offer right now, I think, is better detection and mitigation, but we can't really reverse anything for them just yet. Now the SGLT2 inhibitors, again, I will offer an additional mechanism to retard progression. There are drugs like bardoxolone which may actually reverse chronic kidney disease. Those are being studied in other diseases like Alports right now. So I'm hopeful that we'll have more opportunities. But the state of the field today is we just have to be more aware to pick up so that we can prevent worse problems later down the road. Does that answer, Dr. Banerjee? I think there are some questions on the chat, so give me 1 second. From Dr. Sathe, who's asking what imaging abnormalities do we find in these grown-up children who've got hypertension or grown prematurely? And are there any other changes besides the renal volume? Studying the changes by imaging is challenging because ultrasound resolution is still quite low. And colleagues in both our institution at Washington University and the University of Virginia have actually been working on trying to find ways to be able to develop an imaging technique that can actually measure nephron number. So right now we have no way of measuring nephron number by ultrasound, CT, MR, or any other technique. And so renal volume is, I think, a poor surrogate, the best one we have currently for what is the reduced endowment. And for abnormal renovascular changes, again, the current technologies are things like angiograms, which you would do in very severe cases. You're not going to do an angiogram for everybody, and Doppler techniques are still very insensitive. But the technology is changing. So I expect we'll see better things come up, which will allow us to detect more than just the subtle renal changes. We'll actually be able to see where the hypertrophied nephrons are, and we'll be able to see for subtle renovascular changes, both systemically as well as within the kidney. Does that answer your question, Dr. Sati?
So I have a question also. So you said that E. coli is not meant to be, or that is not normally seen in the flora in the young children. But here we're talking about preterm children. Would the same thing apply to other children who have repeated E. coli infections? They're not preterm, but do you think the same fundamentals will work for them also in terms of pushing them towards cardiovascular or early renal changes?
So for those of you in the audience who may not have heard the question fully, what Dr. Krishnamurthy is asking is, children who've had urinary tract infections with E. coli, would they be more prone to having this dysbiosis pattern? And are they going to then be at risk for things related to chronic kidney disease? And there is a very small proportion of E. coli and proteobacteria that will be present in all of our intestinal tracts. That proportion certainly goes up in the babies with dysbiosis and likely would go up in those who had urinary tract infections. I don't know if anyone has formally studied it to see whether those persist, say, 6 months after a treated UTI. But if it does persist, then it could set up the same mediating inflammatory biomarkers, which the short chain fatty acids go down, and the DMAO and indoxil and p-cressyl sulfate go up. So again, it would be an area to investigate, and then potentially that could be altered also. People could do probiotics or different types of manipulations to get the gut microbiota back into a healthy profile. Again, these are somewhat speculative, but potentially could be used. And a question in the chat. So I have not met Dr. Shanbag now for many, many years, but she was one of my teachers at Nair. So thank you for coming and asking a question. So how early can we pick up these changes in GFR and renal volumes, and when should we start checking? I think that the subtle changes, as you saw in some of the tables I showed, can be present even at age 2 or even at the discharge in the newborn period, which is what we have seen in our population. And at each population, when people are studied cross-sectionally, those changes are present in the groups. So when did they actually start? You need prospective longitudinal studies, or you need studies where there is a prior set of data and a current set of data. So the study by Sangeeta Hingorani's group has given us data from newborn to 2 years of age. And the studies that we are doing and will be publishing shortly have shown you how the cystatin C was back at the newborn period. And now with the studies we hope to start, we should be able to just connect those dots and tell you what's changed in that interval from age 0 to age 10 to 12. And when should you start checking? Really, I think will depend on when we can say that these changes occur. But I would say you should be doing serum creatinine checks, an easy test on a frequent basis. And ultrasounds maybe not as frequent. The periods of maximal growth are when I check ultrasounds. That is usually the first 3 years of life, and then the pubertal age group. In those times, I will check it yearly in most children who need an ultrasound. Others, I will probably, in the in-between ages, I might do it every 2 years. Next question on the chat is, why in preterm we see hypertension during hospitalization goes away after discharge? Neonatal hypertension is probably related to microthrombi that occurs within the kidney. And those babies, my experience is exactly what you're saying here, that this can go away after discharge. Most newborn babies or neonates who I discharge home on hypertension medications, by the age of 2, I would say that 90% of them have gone off those medications. And I think it is probably related to those microthrombi completely dissipating and recanalization of the areas of the kidney that were not receiving adequate perfusion. So in terms of hypertension recommendation for preterm neonates, we have conventionally avoided ACE inhibitors in that age group because of the animal data that say that ACE pathways are important for neonatal development. Almost all of those data come from animal studies, there are virtually no human studies that actually can show that we would harm the babies by using ACE inhibitors in somebody who's say 34, 35 weeks. But because of that convention, we typically use other drug classes, calcium channel blockers, beta blockers, central acting agents as the hypertension recommendations for this age group. So one more question here is, what factors contribute to the gut microbiome disturbances? And any of these actually, or all of these. So antibiotic use, food intake, infection, others, all of them do contribute. That's part of the clinical data we have from this cohort of these 494 babies. We actually know what their antibiotic usage in their newborn intensive care unit stay was. We know what infections they were treated for. And we know how many of them developed either necrotizing enterocolitis, how many of them were on a ventilator. So these are things that we'll be able to associate to the outcomes that we're looking at now. In terms of how to modify them, some of the things that I mentioned earlier, such as the use of probiotics, may make a difference, but that's a field that still has to be formally proven. And so I would say that we are in the early stages of that, where we know that there is an association of the microbiome to chronic kidney disease. We are now trying to make that connection for the preterm baby group as well. And if the mechanisms are the same, we should be able to see if the modifying factors and the different techniques we can use will also modify what we can do for the children.
Are there any more questions?
Thank you, Dr. Sharma, for arranging all this for me, along with Madam Ali and for Dr. Krishnamurthy here. So this has been a very enjoyable experience for me, and I hope it was an informative talk for all of you.
Yeah, I think because of now being more familiar with online platforms, I think it has enabled many people, from different places to join the talk, which formerly would not be feasible. It would be restricted to those over there. So I think there are many people from outside who have joined the talk, and it was really great hearing you. And I guess many of the practices that we currently have are totally destroying the gut microbiome, from what I understand from what you're saying. So we may be adding to the disease processes which develop later in life.
That is certainly possible. Some of it may be also the different dietary habits. That was part of one of the questions about food intake. So in the diets that have less fiber and less vegetables, fruits, tend to be also changing the microbiome in patterns that may be detrimental too. That I think has a direct relationship to the huge diabetes epidemic that we're seeing everywhere. And I want to thank everybody in the Kidney Foundation for Children. This is again the opportunity. I think all of you are doing some great work here, and I applaud you for that.
Thanks so much, Vikas. It's a pleasure having you, and I hope we'll have you again in future at some other point. It was really, as Yashasvi has put in, an eye-opener talk.
Thank you, Vikas.
Thank you.